So I want to make this really a simple talk and just talk a little bit about the evidence, and then just really, I think, focus on who are the people that, that we want to see in the TAVI clinic. Talk about a little bit about the evidence, and I think there's lots of evidence about what we do, but I think there's sort of three major trials, and so forgive me if everybody knows these really well, but I thought it's really, really important to go back over these three major trials and look at why we're doing things. I think the next thing is the most important thing is what we do every week in the TAVI, selection of patients, and then who should you be sending to us? Everybody knows the pathophysiology of aortic stenosis back in first year medical school. I hope you know that. I think this is an important slide. Everybody probably sees this in their practice as well, though. The prevalence of aortic stenosis, as we get more elderly patients, as we're keeping people alive longer and longer, we're seeing it much more commonly. So up to 8 or 10% of patients that we see in their 80s are developing some degree of aortic stenosis. So it's becoming as much of an epidemic, I guess, as atrial fibrillation is. It's becoming an epidemic as we're getting much better at keeping people alive. And there's good evidence, even in there's good evidence in patients who are not elderly, but even in elderly patients and patients who are surgical candidates, there's good evidence that survival is improved by aortic valve replacement. So this is a study looking at octogenarians, so surgical AVR. Clearly, even at 5 years, a 68% survival versus 22%. So this is something, aortic valve replacement is something that we should be offering to our elderly patients. However, as I've mentioned, we have a significant rise in incidence. There's no real medical therapy, and surgical therapy does remain the gold standard. However, we're seeing all these elderly people with significant comorbidities, and before we had this new type of intervention, a third to a half of patients who were elderly were denied therapy for aortic stenosis. So that's really a good rationale for developing a percutaneous technique. So the first one was done 12 years ago by Dr. Alain Cribier in France, April 16, 2002. So it's we've only been around for 12 years now. And I must say, when I first read this and saw this, I was a bit of a skeptic. And I thought that this would be a niche type of procedure. And I'm here to say that I was very wrong about that. So I'm happy to be wrong about that. So his first 50 patients as well showed that he could do this with great success and with great short-term outcome. And this led to some design of some very good clinical trials. And so I'd like to review just sort of, I think, the three most important ones right now. So the first one was called the partner study. And this was done, and I'll go over the two parts of it, the inoperable component. And these were patients who all had to have transfemoral access, and they had to be deemed non-operative by 2 surgeons. And they were randomized then to standard therapy, which they actually did quite aggressive, and they did balloon valvuloplasty or transfemoral TAVI. And I'll talk about the high-risk group in just a sec. They were quite strict. They wanted a valve area of less than 0.8, mean gradient of greater than 40, or a peak jet velocity of more than 4 meters per second. They had to have at least class 2 symptoms and amenable to transfemoral access. There's a bunch of exclusion criteria which I think we don't really take into consideration anymore, but they try to be very, very homogeneous. So these patients, we see here their average age, they're elderly, 83 plus or minus 9 years, mostly female given the demographics. High STS score, so average STS score of 11%. More than about a fifth of them had an STS greater than 15%. High risk of prior MI, previous CABG, stroke. A lot of them had COPD, and frailty, although it wasn't really judged that well, it was a significant number. And I think this is the take-home message. When we take a look at patients who are inoperable, clearly, there's a massive benefit. So we have a 50% mortality at 1 year for patients who have severe aortic stenosis who are inoperable, down to 30%. So number needed to treat 5 people. Very few things in medicine. Perhaps putting people in CCUs with an infarct, transplant, and maybe a VAD. There's very other few things in medicine that give you this much of an absolute risk reduction. And we see even out to 2 years now it gets even better. So 67% mortality in the inoperable group, 43%. So really quite an impressive therapy. The bit of a cost of an increased stroke, as you can imagine, 5% versus 1%, more vascular complications. However, the cardiac death was dramatically reduced. Major bleeding increase in TAVI. And I think the most important thing here, and I'll show you another slide here, was that the amount of patients with greater than one NYHA 1 was 25%. So the patients who had the TAVI were not only alive, but they were feeling a lot better. And when we combine mortality and stroke, even up we look at 1 year significant, 2 years very, very significant. So even with the risk of a stroke, the mortality of stroke was much, much better. And then we look at patients, almost 93% of them, 92, 93% were NYHA 3 or 4. Only 17% at 2 years who got TAVI versus almost 60%. So living longer, feeling better. So at 2 years, patients with symptomatic severe AS who were not candidates for surgery had better all-cause mortality, cardiovascular mortality, repeat hospitalization, and improved functional status. So clearly for inoperable patients, this was an amazing therapy. We even have 5-year outcome now, and it's really interesting. We still see this. At 5 years, the patient's medical therapy, interestingly, 6% of them are still alive. It's interesting to see. And but we still see a pretty robust 22% improvement in absolute risk reduction at 5 years. So it seems to, despite these patients being very, very sick, very, very frail, and deemed too sick to have surgery, we still have about 30% surviving for 5 years. And their functional status is excellent. And I think this is the issue. The ultimate value of TAVI in inoperable patients will depend on careful selection of patients who are not surgical candidates and yet do not have extreme comorbidities that overwhelm the benefits of TAVI. So then I'm just going to go quickly through this. This is the high-risk group. So these are patients that surgeons said, yeah, we'll operate on them. They are high risk. And they assess them for transfemoral. So this is, we're going to go looking at patients. The original partner trial was just transfemoral. Now we're going to take people who have bad peripheral vascular disease and offer them transapical therapy. So they assess them for transfemoral. If they couldn't, they would go surgical or transapical or transfemoral 1-to-1 with surgery. And they had about 700 patients. And again, this is just a little cartoon looking at this is what we do with transapical. Seems kind of scary that we're putting this 18, 20 French, actually 24 French in this thing through the apex, but our surgeons are pretty good at sewing these up. We look at these patients about the same age, in the mid-80s, this time more men. I'm not sure if this is a bias against women in the inoperable. STS scores of 12%, almost 95% were NYHA 3 or 4, a lot of previous cabbages, a lot of previous strokes. Those are the important findings. And then we see at a year, that's for surgical AVR, and we see for TAVI a 2% improvement, although this was not statistically significant. It wasn't powered. And then we go to 2 years, no difference in mortality. A couple of interesting points, sort of hypothesis generation things, is that we actually look at the transfemoral was actually it was lower, 4% absolute risk reduction. Having said that, it wasn't powered for that. And that's kind of interesting when we'll talk about the next core valve trial. While I think even more interesting was that the actual transapical seemed to have a worse outcome. So patients who were, as we go to 2 years, the mortality seemed to be higher with transapicals versus just regular surgery, which I think leads us to sort of, if the patient's a reasonable surgical candidate and we can only do transapical, surgery may be preferred. And we look at, again, early on, there's some, I'm not going to show you the data just for the sake of time, but there was some issue that perhaps there was increased risk of stroke, and it really wasn't assessed very well. But having said that, looking at this all-cause mortality or stroke, there was no difference. The curves are interchangeable. So I think that, I think this really showed. And again, the 6-minute walk test, no difference between the two groups. And I think just for the echo people here, I think the interesting thing, and I think they would probably confirm this from the echoes, we see that the gradients are actually quite good. We see excellent gradients. The Edwards valve, which was used in this, is a little bit higher. But the core valve is even better. But we're seeing comparable gradients and sometimes better gradients than we'd see with surgical AVR. So the primary endpoint of the trial was met in patients with aortic stenosis at high risk for operation. TAVI was non-inferior to AVR for all-cause mortality at 1 year. So TAVI, after this trial, was already the standard of care for inoperable patients. These results indicate that TAVI is an acceptable alternative to AVR in selected high-risk operable patients. And now we go to 3 years again. We have 5-year data in Partner B, but 3-year data in Partner A, so the operable. And now we're seeing, again, almost there's no late loss in either group, 44% mortality both. And again, the stroke is actually, there's no difference as well. So that was a little bit of a concern early on, but it doesn't seem to be a problem when we look out late. So at the Heart Institute, just because I think of our relationship with Medtronic, we got involved with the core valve a little bit early on, and we didn't have early experience with the sapien valve. So we've used this in our TAVI program since we've started. And however, they're a little bit late coming with some data. However, it's better late than never. So this study just came out in May of 2014. So this was looking at the core valve versus surgery in high-risk patients. So they were trying to sort of replicate what the core valve, how it would do when we looked at partner-type patients. Again, similar inclusion criteria, AVA less than 0.8 or aortic valve index less than 0.5 per meter squared, peak velocity greater than 40, and they had to have symptoms. And this was where they were a little bit less strict. They were a little bit more strict on the STS score in the partner trial. This one was it was very vague as far as the inclusion. Basically, 2 cardiac surgeons and 1 interventionalist had to deem the patient at high risk. So they had to have a 30 mortality, what they thought was greater than 15%, but less than 50%. And after they did that, they actually sent it to the steering committee, and they had 2 more surgeons and another interventionalist also review everything and say, yes, they were high risk. So they didn't have a strict criteria for STS. They encouraged it, but they also said to encourage us to look at frailty scores, although they didn't mandate any frailty scores. They didn't say you had to do this or do that. They just said, look at the patient, what do you think? So they looked at about 1,000 patients, 795 underwent randomization, a few people ended up deciding not wanting to have surgery, so ultimately 390 underwent attempted TAVI with 389 successful, and 357 underwent attempted surgery with 353 having successful. And again, so similar age groups, interestingly enough, 83 for the age, female, about the similar, again, mostly NYHA 2, mostly NYHA 3 or 4. But interestingly, these guys, I guess, overestimated their surgical risk, as the mean was about 7%, so more of an intermediate type risk. Now, you could argue, well, there was something about them, they looked at them, they thought they were having a walker, or they had a bad grip when they took their handshake, or they were kyphotic, or whatever it was. They thought they were high risk, but when they actually look at the STS, they were actually much more of an intermediate risk group people than the Partner A trial, which is interesting. And they did look at a little bit of frailty, but this was not inclusion criteria. This was just kind of afterwards. And there wasn't a lot of, interestingly, 90% of them lived independently. And very few of them had deficits in their ADL. So I think really, these weren't super frail patients. They had a little bit, I guess 2/3 of them had a grip strength below the threshold. I'm not an expert in frailty. I'm not really sure what that means. And a fair number of them failed the gait speed, which was walking, I think, 4 meters in more than 6 seconds, which tells me that perhaps either they have a lot of walkers or their walking was impaired in some other way. But other than that, we didn't really see anything really that said these people are really, really frail. And I think this was the outcome that I think that for the people who were doing TAVI were ecstatic about. We saw the 1-year surgical mortality was 19%, so 14%. So again, now an absolute risk reduction of 5% for TAVI. So in these intermediate risk group of people who had maybe some other type of high risk feature, which is hard to quantify, there was a mortality benefit for TAVI. And we look at the major vascular complications, as you'd expect, because we're putting in big tubes in arteries in the leg. There's more vascular complications, more life-threatening bleeding in the surgical group, more acute kidney injury in the surgical group, and more pacemakers, as you know, in the TAVI group, and more atrial fibrillation in the surgical group. And we look at all the groups here. Really, there was no difference when we look at all the, if you're over 85, under 85, male, female, BMI, STS score, even a greater than 7 or less than 7. All these groups seem to have a benefit with TAVI over surgery. And what about stroke? And that was the one thing that we were concerned about from the partner trial. And we saw that the stroke rate was actually quite a bit less as well. So we're seeing less stroke. And I think the big thing was in the partner trial, they weren't really looking for stroke. It was just one of these things, if they diagnosed it, they added to it. Here it was very rigid about diagnosing a stroke, and I think they picked up a lot more strokes in the surgical group that were missed before, because the patient had been intubated for a week and they were a little groggy and no one really picked up that they'd had an expressive aphasia. So I think this is the key, and I think this is really really important. So patients with severe aortic stenosis who are at increased surgical risk, TAVI with a self-expanding transcatheter aortic valve prosthesis was associated with a significantly higher rate of survival at 1 year than surgical valve replacement. So this is the TAVI group, and we're referring everybody to TAVI now. And as luck would have it, we've increased our funding from the MOH. I thought, just in the sake of time, I won't go over this too much, but I think this is, this is obviously, you can see this is a moving target. We've gone from inoperable patients to high-risk patients to intermediate-risk patients with some type of frailty. This study, it was a cohort study, and they looked at patients with severe AS admitted to multiple hospitals in Italy, and the patients treated with either of the two procedures were then propensity matched, and they had 650 patients undergoing isolated surgical AVR and 650 patients going TAVI. This was just presented at TCT. It's not been published. They didn't do an STS. They did a Euroscore, but they were much lower risk patients even than the pivotal core valve trial. And we looked at partner A. The Euroscores were 29, core valve 19, and this observant was 9.8. So very, very low risk patients. And we're seeing here now at a year, very comparable. So no difference in mortality, MACE, rehospitalization for cardiac causes, or rehospitalization for heart failure. So even with low-risk patients, with large groups of patients, there doesn't seem to be any difference. Perhaps there is definitely a mortality benefit. We look at sort of intermediate-risk patients who are frail. One of the big questions, and we won't know this for 15 years, is, are the valves as durable as they are as the surgical valves? It's hard to know. Right now, though, however, there's no signal at all that there's any degeneration. There's no signal that there's any structural problems, non-structural valvular deterioration, stent fractures, deformation, or valve migration. So they appear, and we do have some out to 12 years, just not a huge amount, but they seem to be working just as well. Of course, this has led to an explosion. I think this is really going to help things because we're moving along with the technology. We're getting smaller and smaller sheaths. And we're getting repositionable valves. And I just want to show this because I think this is sort of the way, I think in 10 years from now, where we're going to be going. It's going to make, right now, TAVI is a bit of a high stress for us because we release our valves, and sometimes they're a little bit too high, sometimes they're a little bit too low. It can be very catastrophic. But this is the first generation of the new valves called the portico valve. We've put in about 3 or 4. And if you see here, this is the valve. You can position it and open it up to 80%, so the valve's actually working. Then we can assess, so this is just an example. They're assessing for some AI. We're not happy, that's a little bit too much, moderate AI. So then the new one's the Portico, and the new Medtronic Evolute R TAVI, we can now recapture it and then reposition it and get it in a much better position. So that's going to make our lives a little bit less stressed. It's going to be better for my blood pressure in the lab. Knowing that a few millimeters here or there could be the difference between a great procedure and a disaster. So I think this is what's, I think these are only going to get better. These are the first generation of these retrievable valves and repositionable valves. I think in the future it's going to be even, it's going to make our lives a lot easier. So just in the last few minutes, who should be referred, how do we do it, and who should you refer it to? So as I mentioned before, we have about 90 MOH cases a year. Having said that, we also do some Quebec patients. We've done patients from New Brunswick, Nova Scotia, Newfoundland, Iqaluit. So we're trying to do patients. We do as many as we can. So with this 90 funding, we can do more than that. And we do all the routes. We do transfemoral, transapical, and direct aortic. So we're doing all of these. Transfemoral, both Edwards and core valve. Transapical is the Edwards valve, and direct aortic with the core valve. And as I said, we have a TAVI team that meets. We have 4 cardiologists, 3 surgeons, and a TAVI coordinator and nursing coordinators. We discuss every referral that's given to us. So who are the people that we want to see? Who are the people that should be considered? I think if you look at the, all the data from the clinical trials, I think you should consider it in anybody over the age of 80, especially if they have an intermediate or high-risk STS score. I think anybody who has any type of frailty, if you think they're frail in any way, I think these are the patients that we should be seeing. I think anybody with a walker who has severe aortic stenosis should not be undergoing a surgical AVR unless there's a contraindication. Obviously, we're looking for significant comorbidities, stroke, COPD, renal failure, liver failure. We've had a couple of patients with that. And I think as well, previous cardiac surgery. I think that ups the ante as far as even in maybe younger patients. We've done quite a few patients with previous mitral valve replacements or bypasses, just because it makes it much more risky to go in with a previous sternotomy. And obviously, inoperable patients who are otherwise well-functioning. So who do we not want to see? So I think patients with not severe AS, and sometimes this is a bit of a, it's difficult because sometimes it's, we're seeing a lot more, we're diagnosing a lot more of these patients with low gradient severe AS and low gradient, low stroke volume AS. So sometimes it's difficult, but from our point of view, and we end up working up these people a lot, it would be nice if these were all sort of worked up before with the dobutamine stress echo and we had all that information. I think multiple valve lesions is something that we're not very good at. Especially if there's intrinsic mitral valve disease. Sometimes if we get severe AS and we start to get LV dysfunction, we get functional, MR, and I think that in those cases we sometimes do well. But if we see severe MR due to a valvular problem that's not due to a myocardial problem, they usually don't get better. And the only caveat was, unless a mitral clip is approved. So in these patients, I'd talk to Marino. Or Dr. Masana. I think that's the key. I think we really don't want to see anybody, it's a moving target. Moderate dementia for sure. I think we really don't want to, we get our arms twisted sometimes and we usually always regret it. And I think it's really, really important to have a good discussion with all patients if they have even a little bit of dementia. Because chances are they're going to be worse no matter what we do. Even with the TAVI, they're going to be worse afterwards. So I think it's really important, and it's not uncommon for somebody who's sort of just on the edge, living at home, and we just that anesthetic, and they end up in a retirement after, and if they're not prepared for that, poor two-year survival and poor quality of life, not aortic stenosis. Quickly, pre-TAVI workup, important things. We want to get an echo done here, CT TAVI protocol, and you just have to write CT TAVI protocol. This gives us a lot of anatomical things, and also gives us lots of other findings that we pick up PEs and cancer. We want to make sure we get a cath because sometimes the CT is wrong. We just did a case on Monday where the femoral arteries were considered to be big enough on the CT 7 to 8, and when we did the cath, they were clearly 4 to 5 millimeters. We couldn't do it. PFTs are important, especially with lung disease, and I think this is really important, geriatric workup if we have elderly patients, and then work up any other medical issues, anemia, malignancy, etc. I think Sandy and Reno and I are always happy to see any patients for outpatient referral. There's always someone on inpatient consults, and you can usually call the bunker for that. But also, this is Lorraine's, that's her number and her email, and Lorraine's always happy to talk to anybody about any potential TAVI referrals. One thing would be nice to have if everybody just would do a quick STS score. It takes, you can go online, it takes about 5 minutes to do. And I think the important thing is that, I think in intermediate high-risk patients, TAVI is a great procedure. I think the future low-risk patients, we're doing valve and valve, we've done a few, and mitral valve replacements. And I think this, what Andreas Grunsig did after he did his first PCI, I think is really applicable to TAVI. We're still learning a lot, but I see a great potential. Thanks.